When it comes to the relationship between supply chain work and distribution, I ask myself, what are the social factors behind commodity uptake and use? Do the patients have the right support system to actually use medical commodities? If we want to go the extra mile to reach the last mile, procuring health commodities at the right time is the only first step. Inclusive delivery practices for last mile distribution and leveraging local actors will ensure sustained health outcomes for everyone, including underrepresented groups.
In Ethiopia, there are communities which live in low-lying areas, have no road access and little transportation availability. GHS in Ethiopia had to work with local community leaders, health extension workers, government to determine how to deliver mosquito net to these remote communities at risk of malaria. Pastoralists, on the other hand, often travel place to place seasonally. The GHS team, support from United States President Malaria Initiative, had to take off and work with Ministry of Health and local communities to address both geographical inaccessible communities and pastoralists when devising net delivery strategies.
Stigma and social barriers are persistent challenges to working with people living with HIV in Eswatini. Some people in the community snap the DDD approach by not going to the distribution vehicle because of stigma-related issues. Men in Eswatini are sometimes more resistant to testing and medication compliance, and therefore they are not that open to picking up drugs for themselves in the community, let alone picking up for their partners or spouses, whom you may even find that they have not even disclosed their HIV status to. So inclusive approaches can help overcome these barriers. An example of a partner facility that we work with is a team that visits the community once a week for DDD to specific individuals by appointment. On average, there is a turn-up of about 80%, which is a very good number. Some of their stable patients have benefited from DDD because they do not come to the facility that much often and have improved adherence to treatment because of this. Last week, a doctor from one of the implementing partners called to request for lopinavir ritonavir syrup for a patient in one of the facilities who does not tolerate the LPVR granules. We contacted in the group that we have, in the WhatsApp group that we use to communicate, and the regional logistics officer from the whole region promptly responded to say there's a facility in his region that can be able to share the syrup. So transport was arranged for this syrup to be collected and delivered to the facility in need. This collaboration helps us to ensure that facilities do not run out of stock. Those who are overstocked are able to share the stock and we redistribute the stock among the facilities.
We segregate the transportation mechanism for areas less accessible and used vehicles where possible. Sometimes this means using camels since those are used for local transport. In the hilly or mountainous areas, we have to use donkeys and human labor to transport needs to hard-to-reach communities. In swampy areas or communities living along riversides, this required us to use locally available boats to transport needs. In areas which are not accessible for vehicles, motorbikes are also used to deliver needs, from where local community health workers would then ensure that distribution efforts were carried out inclusively according to the microplans and distribution guidelines, aiming to provide universal coverage by providing one free early line for every 2 people living in malaria risk areas.
Okay, thank you very much. Good morning, good afternoon, and good evening to everyone. I'm James Ruyongo, the Chief of Party, Afia Ugavi, a USAID GSC PSM project, which is implemented by Chemonics. And today I am also your panel moderator. So Chemonics, the sponsor of this panel, is a multi-sectoral international development company with about 5,000 employees and a global presence in over 75 countries around the world. And in supply chain, we manage a variety of programs, including USAID flagship global health supply chain procurement and supply management project. I'm sure you all know about this, which was awarded in 2011. And in our supply chain work, we partner with local stakeholders to transform their supply chain systems and improve performance. And our dynamic portfolio, again, of long-term projects adapt and data-driven private sector practices to build resilient supply chains that have world-class efficiency and ease of use and last mile reach. So that is who we are as Chemonics, and we are very, very pleased to be hosting this panel. And I therefore take this opportunity to welcome all of you. And today we have on our panel Dr. Stavros Nicolaou. I hope I pronounced your name correctly, who is the Group Senior Executive Strategic Trend Development of Aspen Pharmacare Holdings Limited. The next one is Julius Mugwagwa, Associate Professor of Innovations Development of University of College London, and Mrs. Regina Mariam Kamoga Namata, the four names, who is Executive Director of Community Health and Information Network. You also call yourself Chain. And then there is Mrs. Rusubiro Mwamsamari. I hope I pronounced your name correctly. You are the Supply Chain Manager and Technical Lead of Village Reach. So that is the panel that we'll be having today, and therefore discussing the topic which was given to us. And this will be about inclusive responses to public health emergencies in Africa. And as we know, the COVID-19 pandemic and other disease outbreaks have impacted health systems and disrupted the livelihood and overall well-being of people around the world. That we all know, and I think all of us have had a chance to experience some of these disruptions. But we know that despite efforts to address public health emergencies and efforts by governments and other stakeholders to contain the COVID-19 pandemic, we have seen disparities and inequalities related to access to healthcare, and sometimes what we would say exclusion of marginalized and represented communities. So today, our esteemed panelists will explore the challenges and solutions to create equitable access to healthcare services and ensure we achieve inclusive responses to public health emergencies that address those inequalities as well as the disparities. So I will therefore take this opportunity to ask a few questions to the panelists and allow them to respond. So my first question, again, that I wanted to ask, and I would like us to start with Dr. Stavros Nicolaou, and I hope I'm pronouncing that name correctly, is Dr. Stavros. What do you see as key solutions to create equitable access to mainstream healthcare services? And here, I think you should also be able to tell us what you think needs to be done to address the disparities amidst the COVID-19 pandemic, and that also maybe speak to what Africa is, the kind of extreme inequality which has been experienced in Africa. Yeah, I want to give you the chance to start us off.
Great. Program moderator and fellow esteemed panelists, good afternoon, and thanks very much to the organizers for the opportunity. It's a great pleasure to share some of my thoughts with you today. I think that the best starting point is to reinforce the vaccine inequality and uneven distribution that has been experienced globally, most manifest in Africa, incidentally. So as we sit here today, around 8 billion doses of COVID vaccine, mainly dual dose regimen vaccines have been administered. And of that 8 billion, Africa has received 3% or less, a wholly unacceptable position to be in. Of course, vaccines have been proven over the past few months to be the most effective and safest tool that we have at our disposal to defeat this pandemic. Vaccines are about saving lives and livelihoods. The economies in Africa have been badly affected during this period. And of course, I don't have to speak about the public health implications. They are well known and well recorded out there. So the situation that we face is that at the onset of the pandemic, the world was talking about solidarity and equal access to vaccines and other treatments. In reality, that hasn't quite worked out. Now, how do we solve the problem? And that's what you started off by saying, that local problems require local solutions, and local solutions mean building up your own capacity. Africa has very little vaccine capacity and capability at this point in time. We import over 99% of our vaccine requirements. And to place a further perspective on that, we are under-vaccinated in the continent at the best of times, let alone now when you've got this unprecedented pandemic that we're dealing with. We at Aspen were able to provide a local solution, and we're hoping that this can be replicated in other parts of the continent. We are looking as a continent at 2 to 3 hubs, manufacturing hubs. Aspen has been a significant investor in South Africa. Of course, we've got manufacturing operations that we own in Germany and France, and Netherlands and other parts of the world. But our South African operations in a town called Gqeberha, Port Elizabeth, remain our flagship facilities. We've invested significantly in developing steriles capability, injectable steriles capability. And at the outbreak of the pandemic, last January and February, we were using a lot of that capacity to produce general anesthetics and muscle relaxants, all of which are required to ventilate patients. And in fact, we were the largest supplier to Europe of those products, which enabled patients to be ventilated. You will all remember the harrowing visuals that we saw out of Italy and France last January and February. And it was an African company that was able to provide general anesthetics at the time. So that gave us some insight into the pandemic, early insight. And we said, well, we need to do more. We can't just stop there. And then, of course, we became a significant supplier of dexamethasone injections and tablets to Africa and the rest of the world. But more importantly, we saw an opportunity not to even repurpose or pivot. We had capacity that we could convert, sterile capacity, form of vials. We could make that available with a partner to produce vaccines for the continent and the world. And that's precisely what we did. We eventually, in the interest of time, I'm going to cut through a lot of the granularity on this, but we were able to partner at a contract manufacturing level with Johnson & Johnson, allocated a capacity of an annual capacity of 300 million doses, signed an agreement with them in September, did the technology transfer, validation batches, and got into commercial production in early Q2. Now, it is well known out there that we have, as Aspen, produced around 120 million doses of this of the Johnson & Johnson COVID vaccine. We produce it for and on behalf of Johnson & Johnson, but we are also in discussions with Johnson & Johnson to secure a license. A license will put a completely different complexion on this. It will mean Africa will have its own vaccine. And once we get a license, and we're very hopeful that we will get a license, this means that Aspen would then be able to allocate and distribute the product for the continent. Our only real interest here is actually Africa and the CARICOM territories. Those are the two territories. And securing and consummating a license will enable us to start producing an African vaccine for Africans. So my final message here is that if we didn't have this capacity at Aspen, the continent would have been in an even worse position than what it is already. So there's a compelling business, commercial, social, and of course a moral case to be made for securing both the volumes on the continent, but also supporting local capacities to be developed. And then we need the procurement agencies. This is probably the most important thing I'm going to say this afternoon. The global procurement agencies and donor fund agencies need to start buying from African companies so that we can get these facilities to be sustainable. If they're not sustainable, they shut down. By the time the next pandemic comes along, you're left back at square one where we were 20 months ago. So procurement agencies, UNICEF, Gavi, CEPI, we are in discussions with them. They need to support African producers. Otherwise, these facilities are not sustainable and they turn into white elephants. Now, we need Africa to be remembered for African elephants, not for white elephants, right? But that's up to the procurement agencies. They need to buy from African producers. Thanks very much, moderator.
Yeah. Thank you very much, Dr. Stavros. Maybe I would also want to do a follow-up question, a quick one, maybe enough a few seconds, is, are you telling us that Africa has the capacity to produce its own vaccines? And what would it take? Maybe in 20 seconds.
So Africa doesn't have much capacity, right? But what we have proven on the continent is, Aspen, that when you apply your mind and you have the conviction, the courage of your conviction, then you can do these things. Aspen's the world's largest producer of general anesthetics. These are complex sterile emulsions. So Africans can do it. We've proven it. And we just need to work together, and we need the right partners. And then we will build up sufficient capacity on the continent, take care of our own vaccine needs, because I'm afraid when it comes to the crunch, we would probably be the same. When you got to decide who you look after first, your own citizens or somebody else's citizens, guess what you're going to choose? Now, we cannot allow Africa to be at the back of the queue. We've got to move Africa to the front of the queue. We can do it. We can build our own capacities. Thanks very much.
Thank you very much, Dr. Stavros. I now turn to Dr. Julius Mugwagwa. Julius, the question I have for you is this. As we know, despite efforts to address public health emergencies, such as COVID-19 pandemic, inequalities exist in accessing healthcare across systems in Africa. That's a fact. And these disparities, as you know, have been exacerbated by the efforts of stakeholders to respond to health emergencies. Now, from a health systems point of view, what would inclusive response to public health emergency look like? And how do you ensure the inclusion of women and other marginalized groups in emergency responses.
Great, thank you very much, James. And it's also a pleasure for me to be on this very important panel, joining as I am doing from University College London. Yes, I was going to, let me start by saying in my several years of studying health systems, I have not come across a system that is intentionally designed to create or exacerbate inequalities. The intention is in fact the opposite. But what is problematic is the business as usual approach that most systems continue to employ, even when there is a mismatch between intention and reality. But maybe that's a subject for a separate discussion. So looking at the issues of inclusion, so I look at the issue of inclusion as an issue of social justice. And from this standpoint, inclusion is best viewed as a process rather than a set destination or a measurable goal. And for me, an inclusive response to a public health emergency is one that operationalizes the universal healthcare or the universal health coverage model, but only at a fast pace. We are really looking at how we can have all individuals and communities receiving the health services that they need without suffering financial hardship as dictated by the UHC model. But let me also hasten to say that an inclusive response does not just emerge. It bears many resemblances with how the system deals with everyday challenges. We can't just suddenly have an inclusive system when the way we've been dealing with the diarrheas, the normal healthcare challenges has not been inclusive. So there's a strong correlation between how a health system functions on a day-to-day basis with how it can be inclusive in the face of emergencies. So inclusion has a number of elements, among them being a sense of belonging, a sense of identity, issues of agency, relationships, shared values, and all these are conditioned by removal of barriers and ensuring transparency. And this takes us to the building blocks of a health system. We talk of health workforce, the financing mechanisms, the governance mechanisms, the facilities, the medicines, the information and research. So understanding and removing barriers in these blocks and at the nexuses between these blocks will ensure universal health coverage and subsequently inclusive responses. So the other part of your question is about how to ensure inclusion of women and marginalized groups in the responses. And this is a very critical age-old question. And then personally and in my research, I prefer approaches that focus not on individuals or the groups as the subjects that need to be integrated into mainstream or regular settings, but rather to focus on the systems and the identification and removal of barriers from the systems. So the pandemic and indeed even everyday challenges have shown us that the mainstream is actually keeping women and other marginalized groups, or it's actually keeping women and other groups marginalized. So how do you deal with such a system? The approach for me is that system needs to be disrupted. We need to disrupt such a system. Having a palliative or incremental approach to such a system may not work. And this is actually what sustains such systems when we try to do little changes here, little changes there. And yet these systems are actually keeping women, children, and other vulnerable groups marginalized. So the pandemic is probably an opportunity, as much as it has brought a lot of hardship and a lot of pain. But I think it is an opportunity for disruption, because this is what is needed for most systems that have actually been labeled as mainstream, yet they're actually remaining problematic. So let me end here for now. Thank you.
Thank you very much, Julius. I think you brought in a very interesting angle and a very interesting issue of disrupting the system to minimize the disparities or be able to address those disparities, and also looking at the pillars of health systems. I now want to turn to Regina Mariam. And Regina, I would like to ask you this question: is how has your organization responded to public health emergencies, and especially with a view to addressing these health inequalities and disparities?
Thank you very much. I'm very delighted to be part of this panel on this important issue. The Community Health and Information Network recognizes the fact that there are very many marginalized and underrepresented people in our communities, very vulnerable, and their vulnerability stems from the fact that they suffer the double burden of communicable and non-communicable diseases. They are very poor. They have low literacy, as well as low health literacy, and all this impacts their health-seeking behaviors. So we recognize that they're left out in most of the interventions, especially because of the issues that I've talked about. They're also very poor, very, very poor, especially at that level. You find absolute poverty, which again impacts their access to healthcare. So in my organization, we have taken it upon ourselves to, first of all, understand and recognize the important issue of engaging and empowering community, which community I've described of the vulnerable populations, which are underrepresented and mainly marginalized. So our programs have focused on engaging and empowering the community-owned resources, because they're our pathways to these vulnerable people in the community. Through working with village health teams, religious and traditional leaders, we try to reach out and empower them through health literacy. And indeed, we've reached over 1.5 million people through our programs, through our community engagement programs. But we also recognize that partnerships and collaborations with other key actors, with Ministry of Health, WHO, supply chain organizations, healthcare professionals, is all critical, and healthcare professionals at the primary healthcare level. So in our work, we link our communities with primary healthcare actors, as well as the other partners I've talked about. And particularly for COVID-19, where we've been incapacitated in terms of the way we work with our communities, we had to use innovative approaches, again, to ensure that our communities access healthcare. CHAIN is a brainchild behind the Uganda Alliance of Patient Organizations, which brings together patients across all disease areas. That is cancer, epilepsy, HIV, sickle cell, mental health, stroke, and other diseases. So within these networks, who are all member organizations, we've been able to reach the unreached in those communities, working with these networks of the patient organizations, who are very well represented and know the approaches they use to reach their people. And in fact, during the COVID-19, they've been using different approaches, because we realized that COVID-19 disrupted healthcare services for all these different diseases. We had people who were initiated on their cancer treatments, they couldn't access it. People with mental health problems, sickle cell, and as such, many lost their lives. But working within this network and with community-owned resources, we were able to reach these people through different means, using border cyclists to take for them their medication, using media platforms to raise awareness about hand hygiene. Chain has initiated campaigns in the community to do hand hygiene activities, and this is way back from 2012. So already when COVID came in, we already had set up, working through our village health teams, already doing hand hygiene, and we just had to use the media, use mobile phones, technologies to be able to reach out to our communities.
Thank you very much, Regina. I think it's clear that it's important to have a systematic approach to preparedness. And I think what you're bringing out clearly is how you've worked out with the communities to respond to public health emergencies, and especially preparing those communities. Perhaps at this point, I would also want to share with you some of the interventions that we have done here in Kenya. As Afia Ugavi, part of the Chemonics team, in 2019, we developed what we are calling a emergency supply chain playbook, which was done in response to WHO joint external evaluation that demonstrated that Kenya lacked preparedness in deployment of medical and non-medical countermeasures during emergencies. And the playbook therefore looked at mapping all the possible or potential infectious emergencies or diseases, looking at a mapping of the personnel who would be required in case there is an emergency, where would the finances come from, what are the logistic systems that are available in the country, and how do they need to be aligned to respond to emergencies, and also looking at disposal systems for infectious diseases. Just like now we are having COVID and other diseases that couldn't emerge in the future. We don't know about the future. So this playbook was customized by Kenya through a multi-agency team comprising of officers from the Ministry of Health, Ministry of Agriculture, Livestock and Fisheries, as well as the Ministry of Interior. And it took a One Health approach. And we noticed that in 2020, when COVID outbreak was reported in Kenya, this playbook was quite instrumental in helping the initial response. And we note that many other African countries have since customized this playbook to their own context so that they can strengthen their supply chain preparedness for emergency infectious disease outbreak. I thought of sharing this experience because, again, for you to be able to respond effectively and minimize the costs of response, you need to be prepared, because sometimes when you are not prepared, then it takes longer to respond and it costs more. But we know today that when you are prepared, it takes shorter time and it's less expensive. So yeah, Regina, thank you very much for sharing with that community response. Now I want to turn to Rusubiro Mwamsamali, and that name, I hope I'm pronouncing it correctly. So she's the supply chain manager and technical lead for Village Reach, and I know Village Reach is doing great work. So Rusubiro, I want to ask you, what role can community health workers play in emergency responses? So from your perspective and from what the work you're doing at Village Reach, so what is it that you can say is the role of the community health workers?
Thank you so much, James, for your question. So as we all know, pandemics begin and end in communities. And Regina has already shared so much about how they have utilized community health workers to be able to respond to the COVID pandemic and the critical role that they play. So I just wanted to let everyone know, like, a little bit history about Village Reach. Village Reach actually started during a crisis. So in the year 2000, when Cyclone Edwin hit in Mozambique. So during that crisis, our founder was asked to provide satellite phones and also equipment for rural communities in Mozambique. And during that time, that's when they realized that one of the greatest barriers for rural communities to accessing any goods, services, including health services, was infrastructure and supply chain related challenges. So as Village Reach, we've been able to still build up on that to be able to identify supply chain barriers and also any challenges that restrict anyone from accessing health services. At the same time, we've also been very big on equity in the way we implement our projects. So currently, for all our projects, we incorporate an equity approach. So specifically to community health workers, we know that in most African countries, more than 50 or above 50% of the population do not live more than 5 kilometers away from the nearest health facility. For example, here in Liberia, more than 80% of the population can only be accessed by the community health worker. And this was very prominent during the Ebola crisis, that the Ebola crisis could only be ended by the community health workers. So during public health emergencies, it is very clear that community health workers are critical to playing the detection role, knowing exactly who has been affected by that public health emergency. Just like Regina initially mentioned, that some of the sickle cell patients could no longer access treatment because of lockdowns and so many processes that were put in place in order to contain the COVID pandemic. So community health workers make sure that these people in their communities can be reached to be able to access those services that they need, and at the same time providing that protection as like the first barrier in their communities to protect against new infections. And because they're like a trusted personnel, they're also utilized in health promotion and can also be used for behavior change, just like the hand washing stations that Regina also already alluded to. And lastly, they're critical in limiting the spread of infections because they help in isolations, monitoring isolations, and also referring sick people to the next level of care because they understand the processes that they need to take to be able to refer people.
Oh, thank you very much, Lusubiro. And I think I like what you say, that pandemics begin and end in communities. And I think the Village Reach is doing a great job to ensure that you empower those communities so that they have the preparedness, they have the capacity to respond quickly to minimize spread and even sometimes stop the spread of those emergencies. And also be able to communicate the interventions easily within the communities where they live. So that is great work. Thank you. And now, as we get towards the end, I wanted again to circle back to Julius, because Julius made a very interesting statement that he sees the solution coming from disrupting the systems. So Julius, I want to ask you a very indirect question. Given what has been learned from the COVID-19 pandemic, how confident are you regarding more inclusive responses to public health emergencies in the future? What are we learning from COVID that can be applied to future systems that will ensure inclusive responses? Julius.
Thank you very much, James. And thank you all colleagues for the very fascinating work that's happening on the ground. So, yeah, regarding confidence, how confident I am, I would say one would really want to be confident and to remain confident, because, I mean, without confidence, there isn't much that you can do, and all the responses that different organizations are championing, like what you are hearing from Lusu, from Regina, even from the private sector as well. It's all a function of the confidence that is there to keep going. And that confidence for me, I think, is conditioned by how we deal with day-to-day challenges. So that is really important, including COVID in this instance. From a health systems perspective, and in terms of facilities and institutions, maybe a lot still remains inadequate. We have probably not moved fast or far enough to embed some of the requirements and some of the learnings. I think that is always going to be work in progress. How do we embed some of the lessons on working at speed, working at scale, being more inclusive? So there's a lot that still needs to continue happening. But I would want to say that with respect to bringing back compassion and a human face to how we deal with societal challenges, I think COVID has brought a lot of changes. COVID has created that existential imperative, the real need, the urgency of actually dealing with issues. So the hope is that hopefully we do not slip into some kind of collective amnesia or an adversity normalization mode. You know, when the pandemic goes, we then slide back to business as usual and we say, I know we have overcome this, we'll also overcome the next one. And I think some of the signs might already have been starting to come back. People relaxing already, you know, people thinking, oh, the West is over and all that. So hopefully all the things that have been learned and that need to be embedded can be embedded, and then that will really sustain the confidence. So on a positive note, I would say the pandemic has opened up the healthcare space and repositioned health as an integrative matter or an integrative issue for all facets of the economy. You know, people in industry, people in manufacturing, people in trade, you know, any aspect of the economy you can think about has really seen how they need to put health at the center and at the front of their thinking and their operations. So that is really a positive thing that is good for the confidence going forward. So this actually gives me hope and confidence that health will receive due care in terms of financing, for example, because that has always been a critical issue. The requisite capacities that are needed at different points in the continuum, we are probably going to see a lot of prioritization being put on that. And then very importantly as well, the political attention that health needs, that movement from political will to political action. There's been a lot of talk, a lot of targets that are set, but you don't see that translating into political action. So hopefully, because of what the pandemic has done, we will be able to see a lot of political attention that translates into political action. After all, the travel restrictions that you have seen have meant that everyone has to seek healthcare locally. including some leaders that maybe were able to travel to other countries, but now they've had to just look for healthcare locally. And I think that raises the imperative to strengthen health systems and making them better prepared for more inclusive responses. So how confident I am, maybe I cannot put a figure on how confident I am, but definitely all the different aspects I've highlighted maybe an indicator that there is definitely confidence there that has been generated from the responses that you've seen, and confidence that can be sustained by the way that we embed and harness some of the lessons that I imagine from here. Thank you very much.
Thank you, Julius. Indeed, there is hope, and I can see the confidence, and I believe that we will be able to translate the learnings into action. At this point, I want to give each panelist an opportunity to give your final words before we conclude. And I would like to start with Regina. Regina, if we can have your final words, your parting shot, yes.
Yeah, for me, I think the missing link in all these responses is really community engagement and empowerment. And I know that we cannot cope without engaging and empowering these communities. And if we do that, I know that we will go a long way, because even for the vaccine, you can see that in the beginning, it was top-down approach until countries realized that communities have to be involved. A lot of myths need to be demystified to help increase the uptake of the vaccination. So I cannot overemphasize the power of community engagement and empowerment.
Thank you very much. And next is Lucy.
All right. So for me is knowing the risk and also understanding is very important for us to be able to know where exactly to start from and who to engage. We know what works, but usually governments in Africa have not included the community health workers as a recognized cadre. They're not well equipped to be able to handle these public health emergencies. They are not usually paid, but we know that they are very critical in ending pandemics. And I believe that inclusive response is possible only if we have visibility. And if we have visibility, it's possible to be efficient during public health emergencies, because everyone knows who is doing what and what their role is during a public health emergency. So it's a call for government to be able to recognize community health workers and make sure they have what they need to be able to take on this role, because they wear so many hats during pandemics.
Thank you very much, Rusu. Now I turn to Julius. Julius, I know you have said very, very interesting things, but we still want to hear your closing remarks or a parting shot. Julius.
Great, thank you very much. So my closing thoughts revolve around this whole notion of, I'm saying my closing thoughts revolve around the notion of mainstream healthcare services. And I think for a long time, we've lived and operated in a reality where we think addressing healthcare inequalities and disparities is about increasing access to mainstream healthcare services. But I think the pandemic has shown us that we need to decenter all this. We need to rethink what we mean by health, by mainstream. We need to think about different ways of making sure that access to health is expanded. So whatever we mean by mainstream healthcare services, I think we need to rethink that, because the reality is that mainstream healthcare service provision is what led us to be where we are now, with the institutions or services that are not inclusive, or services that are not able to respond in a way that is inclusive. So how do we rethink them? How do we reposition and reimagine healthcare systems in a way that doesn't keep us in the same space, or where we don't think about building back better? There's that mantra going on globally that it's about building back better, but back is where we are coming from, and that's where we are having problems. So how do we think about building forward better, or maybe building together better? In that case, maybe we might actually end up with having multiple streams of healthcare, not just one mainstream healthcare system. So that's my parting shot. Thank you very much.
Thank you, Julius. And finally, Stavros, if he is back. I'm not sure he has finished with the minister, but if he has come back, Stavros, this is your turn to give us your closing remarks. Okay, it looks like Stavros is not yet back, and therefore I think we have to bring our panel to a close. And I think what I would say is that the panelists have demonstrated that there is hope in achieving inclusive responses to public health emergencies in Africa. And what is coming across very clearly is that this will be realized through collaborative efforts amongst all the stakeholders, and also borrowing quite a lot from the private sector and best practices, especially for health supply chains. So what really is the message today is that we have learned quite a lot from the pandemic, especially COVID, because it was unique. And therefore, we must translate this learning in action moving forward. So, ladies and gentlemen, I want to thank all of you. Thank you very much.